Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Let's do this, everybody. Okay, guys. I hope you know Gregg Johnson, who is a physical therapist, a world-renowned physical therapist. You're famous, Gregg Johnson.
Not to my knowledge.
This is so cool to have you on. So I'm going to do a bio to talk about how amazing you are, all of your experience and ways you've really changed the world of physical therapy. I met you, my husband's a PT, so I knew of you, for a while, but then I saw you presenting at our Airway conferences, like the American Academy of Physiologic Medicine and Dentistry with Dr. 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 and other conferences. And I thought it's so cool that this gap is being bridged with physical therapy, breathing, posture, sleep, muscle tone, and it just connects so well. So let's go over your bio. Gregg Johnson graduated from the University of Southern California in 1971 and completed a one-year residency program at 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 under Maggie Knott. He remained as senior faculty for 6 years. Mr. Johnson is best known for his identification of the need for physical therapists to integrate treatment of the fascial system into manual therapy and the development of the first soft tissue mobilization course for physical therapists in 1980. That's so cool. Amazing. In addition, and let me say one thing, my husband's company and his physical therapy philosophy is all hands-on. They do exercise-based approaches, but the manual therapy is key. And I've been to physical therapy before in places where they watch you just do things. And our company and how he works is you got to touch the person hands-on. And I know he takes a lot of your courses, hosts your courses. And so that's amazing that you were developed the first soft tissue mobilization course for PTs. In addition, Mr. Johnson utilized his extensive background in PNF. So what does PNF stand for?
Proprioceptive neuromuscular facilitation. And if you've ever heard of the word contract, relax, or something along those lines, it was developed by Dr. Herman Cabot and Maggie Knott at 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑 back in the late 40s and early 50s. And it's an approach to making movement easier for a patient. It was developed for the neurological population, but it's so applicable to every individual, not just every patient, but every individual, because it has the means of tapping directly into the central nervous system and influencing the motor and sensory cortex.
So is that like if you're treating a patient and you're applying pressure in a hands-on technique and you're having the patient, like if it's the neck, you're saying like turn movements? Or
No, it is more of me adding resistance. So with every movement that we make, we can find ways of resisting it. And Dr. Cabot and Maggie developed diagonal patterns for the extremities and trunk. Each one of them, when you perform it on a patient, you can selectively evaluate how well their core is firing, the strength within it, and look at every component that creates that movement and very quickly be able to identify the weaknesses that they have and be able then to apply facilitation techniques, which means making it easier for them to learn how to do that movement.
Okay, interesting. So you utilize your background in PNF to adapt standard manual therapy techniques of joint mobilization and develop the dynamic techniques of functional mobilization and resistance enhanced manipulation, what you just described, techniques for joints, soft tissues, and neurovascular restrictions. Mr. Johnson has trained or directed the training of over 40,000 therapists in the USA and internationally, and you are the co-founder and president of the Institute of Physical Arts, so IPA, and the co-developer of Functional Manual Therapy Approach to Patient Care, and the director of an APTA credentialed AAOMPT fellowship program in functional manual therapy. You've published multiple chapters and articles on soft tissue mobilization, PNF and the orthopedic patient, functional mobilization, and functional tests for the lumbar patient. And you're also involved in several research projects on functional manual therapy. And you're also the senior fellowship faculty in the IPA fellowship program at IPA Manhattan. And you co-treat and teach and do everything. You got a lot, and there's a lot of like bullets by your name of all these trainings and things that you do. And it's amazing. Thank you so much for being here.
Well, you're more than welcome. I'm actually very excited. The subject that you have taken on for your passion, the airways, looking at it from a myofunctional standpoint, is such an important part of human health. And really the last 10 years, the expansion of research and the expansion of awareness as to the importance of our airways and how our airways integrate with every other aspect of our whole system. We could later on get into those interconnections of efficient airways, how they provide us our health. And so they become foundational, I believe, in almost every patient that we see for being able to be evaluated for the patency of their airways.
And when did you become interested in this airway component to physical therapy? I assume it wasn't like an initial part of training. When did that occur?
Well, it really was. That's very
Oh.
fascinating that you asked it. And in contemplating and getting ready for this, looking back for Airways, it would really go back to my 7 years at 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑, because a major part of PNF is doing resisted breathing, of training the diaphragm, training the rib cage, training the individual how to breathe more efficiently. And what we found was so many of our rehab patients, whether it was a brain damage patient, someone with multiple sclerosis, someone with a stroke, uh, if they could enhance their airways, their physical function would improve. So sometimes foundationally, it was just enhancing those. We didn't know as much back then. I didn't know as much back then, but I was always amazed at how when somebody really gained more control of their breathing, how much more effective I could train them in walking and sit to stand and rolling over in bed and their functional activities.
Okay, so when you say enhanced breathing, um, what does that mean? Like changing posture, teaching them diaphragmatic breathing? How do you enhance someone's breathing with physical therapy?
That's a great question. I kind of threw out an answer without really describing it. And I would say that again, that resisted components.
Okay.
We use, let's say for the diaphragm, we resist the viscera. And so the diaphragm, as it descends down during inhalation, moves the viscera down into the pelvic floor, towards the pelvic floor. We can take those visceral organs and pushing them up against the diaphragm and provide resistance in supine as they breathe in. And so we can use tools such as a quick stretch to facilitate the diaphragm, prolonged holds to facilitate the core fibers in the diaphragmatic mechanism, so that we develop a much more tonic first approach. And so that's diaphragmatic breathing. Rib cage breathing, just as important, even though we do emphasize diaphragmatic, we have to have our rib cage breathing for coughing, for being able to do exertion. And so we do the same kind of resistance to the rib cage, retraining those lungs to be able to expand fully, training the rib cage and the ribs themselves to mobilize, to fully expand, and even going in and mobilizing each rib to make sure that it's in its optimal state.
Hmm. So why would someone initially like not be a good diaphragmatic breather or have problems where in this area of breathing? Because 100% I do. Like like I know the thought of diaphragmatic breathing, but I'm all upper accessory breather, right? What
But you
why
are.
does that occur? I know. Don't show my neck, don't, but when I speak, and you think I would know how to do this, right? This is what I do. I'm a speech pathologist. I know about different techniques, but I always strain in my throat and tense here. Why does
And
somebody develop these
you,
issues?
you can hear that in you. And I'd love to have an opportunity to see if we could make a change for you.
Yeah.
Facilitate it so it'd make it easier for you to do it naturally without having to think about it. I'm going to go down that road just a second, if you don't mind. Is that
Yeah.
a lot of our training that we do within physical therapy and other ones is to really go in and do something cognitive. We tell the human mind what they need to do. And there's some real problems behind that, because all of our motions that we have, all of our movements, our breathing and everything else develop naturally through the developmental sequence. And so to me, the question is why don't we go back and recapitulate those components that we initially used to develop our skills? Why don't we go back and retrain that way so they're done naturally? So for me, foundationally, anything I can do in training that I can facilitate the body to do it naturally and not have to be something they even think of cognitively is much more efficient. So my whole 54 years of being a PT has been oriented around discovering tricks, means, methods to help someone to become a more natural breather, to provide movements with many options for their life. And so I would say, in answer to the question, I go for as much as I can to train someone to automatically do something to avoid going into cognitive mechanisms.
That makes perfect sense, because it's almost like in certain facets, I can describe how someone should be breathing, but to initiate it, or patients can initiate that. But when it comes to that subconscious level where it's not on command, that carryover of correct breathing, it sounds like there's different ways to do it.
There are, but with your question that you asked about why does it happen? The research really hasn't given us clear indicators. So everything I'm going to share are my clinical impressions. They're my thoughts. I was going to say beliefs, but they're not beliefs, until they have proof to them. I watch infants, and I spend a lot of time watching infants. And if you noticed, vast majority of infants are natural diaphragmatic breathers. They lie there and they're breathing in their belly. They have nice rhythm. They are able to take a full breath in, and they're able to let their breath out without effort. They don't close off their airways. As I watch those infants develop, there are critical points that they can start losing that capacity of diaphragmatic breathing. Now I'm going to step back and answer a question. I have treated also infants who have gone through difficult childbirths, who've had a cord wrapped around their neck, who have been breech, even those that just are C-sectioned, don't have that natural pushing of the fluids out of their lung that happens in the birth canal. And I will see many of them not having that natural diaphragmatic breath, and they start out with it. But that's not the majority of our subjects. But when we jump all the way forward, in my clinic, I would guess that maybe 20% of my patients are natural diaphragmatic breathers. Maybe. And that's a stretch. But then I would say that of the 80% left over, there's another 10 to 15% that can breathe diaphragmatically, but don't. That leads to a huge component of those that I see clinically. And I'm talking in the thousands of patients now that I've observed who just don't have a clue how to use their diaphragm to take a full belly breath.
That would be me.
And that is that process. So how did that happen? So we get into that stage where we start training, or we as an infant start wanting to learn vocalization, how to speak. What we have to do to speak is tighten our diaphragm. What we have to do to speak is to work our throat. We have to close down our throat. Crying is a totally different thing, and cooing and everything else. But speech production all of a sudden starts changing. And I start seeing, by the time the average child is 2 and 3, that there is a decrease in their diaphragmatic breathing. Then I think there are critical stages in our lives in which fear, anxiety, let's stay with fear and anxiety. drive us that we are dropped off at school and we're now alone with a bunch of people we don't know. And all of a sudden we start clenching up and very quickly start tightening our abdomens and tightening our throats. And all of a sudden now, by the time we see 6, 7, 8-year-olds, the number of diaphragmatic breathers have even dramatically dropped by that age. And I believe that it's because of societal responses to our environment and how we respond and how we're not prepared. I wish that I knew this much as I raised my sons, because I would have spent much more time observing their breathing patterns to understand the state of their internal environment. That is a critical aspect, as far as I'm concerned, to understand someone's internal environment.
Really interesting. That sounds like it makes perfect sense, and that it's like a vicious cycle. I think if we're talking about anxiety leading to poor breathing, but then poor breathing patterns leads to more anxiety, right? When you're not getting full airflow. Wow, that's interesting. I did have a
And
lot
I
of
think
anxiety.
what
Yeah.
And I think what we have as a society, if you kind of look at the polyvagal theory, and my most recent last 10 years, passion has been the vagus nerve and really looking at the autonomic nervous system. But if we take a look at it, a vast majority of our society does not have a strong ventral vagus nerve function. They are on either a dorsal vagus nerve or sympathetic state. And those two systems are now running their lives. And it can usually be told that an individual who does not breathe diaphragmatically has a very difficult time ever getting on a pure parasympathetic state. So we're talking now that 65 to 80% of my patients do not have full access to their parasympathetic system, which, as you know, is the critical one for our health and for our well-being and our state of mind and our staying away from anxiety and depression and how we control our responses to stresses in our environment.
Right. And a lot of our patients who are mouth breathers are not breathing diaphragmatically. And we really see
Yeah.
that connection, right? Clinical connection with mouth breathing and heightened anxiety. And then that impacts your sleep quality as well. And it's that whole cycle. And once you get into that cycle, it's hard to get out. You need physical therapy, you need myofunctional therapy. Then the bones of the jaw and face have grown differently if these issues occur in childhood, right? And it's a whole cascade. Can you talk about the polyvagal theory, the vagus nerve, all that? Because that is just really interesting.
Well, to me, it over these last 10 years for me, it is just completely, uh, I think it's 76 years old. I would have retired if there wasn't some new passion always driving me. And thank God for the last 54 years. Every year I can say that was my passion. That was the component that I wanted to help patients with, that I was fascinated with, that I was unsuccessful in helping, that I felt inadequate. But it really has been this whole aspect of the autonomic nervous system. And Stephen Porges developed the polyvagal theory around, actually, first of all, newborns. And what he noticed in those who had had stressful births was that their parasympathetic system was not functioning. And he started doing much more research into it. He eventually identified that in humans, our vagus nerve has a myelinated and unmyelinated component. The myelinated component is the more advanced, does not exist in most phylums. It's only in mammals and only in certain degree of mammals that have a myelinated vagus nerve. So it is a more advanced vagus nerve. And as he started studying this myelinated component, he started realizing that it was really what he calls hierarchy. It controlled the autonomic nervous system. We'll describe the autonomic nervous system a little bit more in depth in just a second. So he identified that as overseeing it, and therefore it would control all aspects of our autonomic nervous system, which is that which is automatic. It's what drives our ability to digest food. It's our survive. It's our ability to sleep. It's our ability to have trauma and overcome it. There's a great book out there that says why zebras don't get ulcers.
Mhm.
And it, for me, really just that describes it. As zebras can be attacked by a lion and within 5 minutes be back on a parasympathetic and survive it, and then be on a parasympathetic state and go back to eating. We human beings have our boss tell us that we stink, and 5 days later we have still not regained our sleep or anything else. We don't know how to let go, and so we spend most of our lives living in the past. When you're living in the past, you cannot have an active ventral vagus nerve because it would automatically control the way that we learn to forgive, to overcome, to move forwards, etc. So the other two components, the sympathetic, as you know, is that driving force that keeps us really active. It's the one that, when we're in competition, combines with the parasympathetic, which gives us our control and our ability to have coordination. But it's the one that gives us our drive. It's the one that protects us. If we get attacked, we can get out of that alley as fast as possible, only because the sympathetic system closes down all of other aspects of our body and takes over, and we get out of that alley alive, or we perform whatever we need to do to be safe. Our problem is then the sympathetic system rules us because we haven't learned how to return back to that parasympathetic state. So we get increased blood pressure. We end up with poor digestion. We don't sleep well. Our breathing changes because we're on tension and we don't breathe diaphragmatically, and we lose all of those components that should be there. And so that's a look at that, the autonomic nervous system. And it is critical because in its healthy state, you will not develop or should not develop autoimmune disorders. And autoimmune disorders have exploded in our society. And not only that, the identification of them. An autoimmune disorder is basically when our own body attacks itself. So we do that in Parkinsonism. We attack our own substantial niagara and destroy the cells that actually keep us coordinated. So we become Parkinson. Or we end up attacking our thyroid gland and we get Hashimoto's. Or we get diabetes 2. Or there's so many of them. We end up with fibromyalgia, etc. All of those, and there's 122, I think now, syndromes that they've defined as autoimmune disorders. All of them are also coupled with poor breathing patterns. So it takes us right back to airways. I have never treated someone with an autoimmune disorder that has efficient airways.
Hmm. And efficient airways meaning good use of the diaphragm and rib cage for breathing.
Yep. Not
Mhm.
holding your breath, during activities, being able to sleep and breathe through your nose, not being a mouth breather, of having the diaphragm being your relaxed muscle of breathing, and having everything go into belly breath. That is where we should live. And
Okay.
yet, and what's so fascinating, we got to go in the 1990s to Africa, and we got to be among the Maasai tribe. And among many observations I had is there wasn't a single one of them that I saw that didn't breathe diaphragmatically. They don't walk around holding a six-pack, which absolutely eliminates us from breathing diaphragmatically. If we're holding in our bellies, we stop diaphragmatic breathing. Didn't
Okay.
see any of them lifting their chest up looking like they were strong and powerful and wanting to look presentable.
Mhm.
For whatever reasons, we hold our chest up in a habitual pattern. Didn't see any of that. And so as I've gone in and looked at a lot of National Geographic videos of hunter-gatherers who live more off the land, you don't see the habits of breathing that we see in our society that we've developed. So to me,
Well,
breathing is a evaluator of our state of being, and it is also a pathway to show us that we are not as healthy as we should be.
It's so interconnected. It's interesting you say that because we know dental skeletally, the hunter-gatherer population has wider jaws,
Much
larger airways, probably not suffering from apnea. It's all related, right? Like Dr. Kevin Boyd says,
more.
the cranial facial respiratory complex,
That's it.
all interconnected.
All of it's interconnected, and that we know is driven, as you know, by the fact that many of us were never breastfed.
Mhm.
Personally, my mother was told, "Oh, Donna, don't breastfeed him. Formula is far more healthy for him." So I got shoved cow's milk down my throat, which I became allergic to, of course, which most people do.
Mhm.
Formulas and those things are not what is designed for the human system. But with that, bottle feeding never duplicates nipple feeding. And therefore, use of sucking the nipple with somebody that does not have a tongue tie, it creates the face, which is what you indicated. And so it expands the hard palate, it expands your nasal cavities, and breastfeeding and early chewing of more complex foods, not just Gerber baby foods, because I would say in the jungle, they don't have blenders or Gerber baby food, but
Mhm.
yet their infants learn to chew and take on much earlier. And
Right.
in those environments, we know that the average adolescent may breastfeed up to 2 and 3 years old.
Yep. And I say nursing is the catalyst for good orofacial growth and development. It's like
Completely.
myofunctional therapy, right? You're working the muscles and then chewing, mastication builds and forms bone. And our,
All you're
populations that
doing,
lacking these things are suffering because we're losing bone growth.
and that is exactly what myofunctional therapy, one of the components of it that's so powerful is the fact that it's reduplicating, no, it's doing what should have been done through breastfeeding for that adult to now be, or adolescent, to now overcome that lack of breastfeeding. So
Mhm.
the good news is our society is so much different than hunter gatherers. There's nothing that we should be more proud of that women are in the workforce and accomplishing like they are in this society. For a lot of them, it's a very difficult decision at that 3 month period to go back to work. What do I do? How do I take care of my child? Well, I think the good news is we have so many options now that we can help those infants through myofunctional therapy and through functional manual therapy to regain what they would have gained if they had gone through breastfeeding. So I don't think that there should have to be a lot of guilt around not breastfeeding. There needs to be responsibility to make sure that those structures are now addressed.
Right. And somebody could have nursed their baby for 2, 3 years, and that child still could have issues if there are
No
other
question.
things that aren't addressed, like you give them a sippy cup or they have a digit sucking habit or allergies, right? Your thumb sucking or allergies or there, other things can trigger that. So we can't be perfect humans and do everything correctly. But you
Correct.
said things can be addressed with functional manual therapy. And can you talk about some of that?
Well, that's what I've developed, and I also want to just give a shout out to my amazing wife Vicky. Without her, everything that we've developed in the Institute of Physical Art could not have happened by us being separated and not together. So it's one of those uh, uh, happenstances of life that completely changed the direction of the future. And so everything that is in functional manual therapy, I would have to acknowledge has been jointly developed with her and also with many others. We have to say that we stand on the shoulders of giants. Uh, the only way that I am a good mentor, effective mentor, a good therapist, an effective therapist, really stands on those individuals that I studied with, that I learned from, who poured themselves into me to allow me to be where I am today. And so nobody gets to be effective at what they do in an isolated environment. So I first want to just acknowledge those individuals. But functional manual therapy is the use of our hands to evaluate any system, any place in the body. There's nothing in the human body that I don't treat, that I haven't studied, that I don't try to address, from the foot and ankle of the cranium, from the brain through all the viscera, through respiratory function. And we need to know that because we are now understanding that the human system is completely interconnected. If I don't have efficient airways, it affects my digestion. It affects my ability to even have endurance. The way that my muscles develop are affected by having poor airways. If I don't have good digestion, if I develop irritable bowel syndrome, it may affect my back. I may end up with back pain that is related to the irritable bowel syndrome. So the only way that we as physical therapists can truly be able to evaluate and treat is to be able to understand the system as a whole and study it as a whole and start recognizing the interconnections. We start seeing, I treat a foot and ankle and someone's posture improves and their breathing improves. Why did that foot and ankle change everything else? So I know I'm going on and on here,
Yeah, keep going.
but but what it is basically we go in and evaluate all of the airways, every component of it, which is extensive, that are part of the airways, all the way from the pelvic floor up to the tentorium of the brain. And all of those individual components can be in a dysfunctional state. And through treatment, we can take those mechanical dysfunctions that we find and treat them, such as in the hard palate. The hard palate never expanded in the intermaxillary suture. So that intermaxillary suture never allowed it. So we have these high arched hard palates. We can go in with our hands and spread those hard palates and do with manual therapy what the orthodontists do with hard palate expanders. In fact, before we let anybody really go in to get a hard palate expander, we gain everything we can possibly gain through hands-on treatment by expanding them. You can do that through it. With functional manual therapy, we don't do it passively like the osteopaths and chiropractors do. Everything that we're mobilizing is done while the patient is either actively moving or we're doing resistance to them. And so those are the major components that we do. So that's functional manual therapy, looking at all the components, treating their mechanical, which is what I described. But as soon as we do that, we need to make sure their motor system is efficient. So we go in and start assessing. Do they have what Vicky calls a core first strategy, meaning their tonic muscles come in first, which is what the researchers call a feed forward mechanism. And so even in something like the diaphragm, it needs to be able to have their core muscles firing, and it needs to have a feed forward mechanism. So we go in immediately and re-educate those areas that are not a tonic, that are not a core first strategy, and start facilitating those core muscles through resistance. And then we come back and do motor control, which is basically training and coordinated movement and options for movement.
Okay, so you talked about like belly breath. No, this is so fascinating. Like, okay, when we talk about diaphragmatic breathing earlier, you said belly breathing, which it's diaphragmatic breathing is not really belly breathing like I was taught you use. Your ribs have to go expand in the front and back in all dimensions. Can you talk about what diaphragmatic breathing should be like?
Well, this is why what you mentioned earlier is so important, is posture.
Okay.
Because for
I
the
was like, that's
diaphragm,
great. I'm
yep,
like
because
adjusting.
for the diaphragm to function efficiently, it has to be completely able to be in a vertical position, so that when it descends down, it moves the viscera down, but it moves it down against the pelvic floor. So the pelvic floor and the diaphragm need to oppose each other so that they're constantly working together, moving the viscera up and down. So the optimal diaphragmatic breathing is truly a vertical breath in which you will feel expansion in the abdomen, in the back, and laterally. So there's a three-dimensional breath that really occurs in more efficient diaphragmatic breathing. So pure belly breathing, and we really got that from yoga, is let's do our belly breathing, is an easy way to start seeing if that diaphragm is really functioning. But the way you know you've got efficient is when you breathe in to your pelvic floor, you feel your back, the lateral expansion, the abdomen expand, and that lower part of the cage flare out just slightly as that diaphragm descends down and moves the viscera so that the lungs now can fill up passively with air through the airways.
That's a helpful thought. So by kind of being more vertical in your posture and then vertically breathing, that that's a visual actually. Because when I hear
And then,
people say belly breathing, it almost makes you think you want to like stick your belly out, right? And your
yeah,
belly pop out. But that's too much of a focus on
no
um
question.
horizontal, right?
Well, if you really look at individuals in a standing position, let's say, that have to do a fine motor control, let's say someone's standing and playing a clarinet or a flute or a trumpet or a trombone, or a marksman having to be able to uh, hit targets. If they use it all diaphragmatic breathing, that's belly breath, their body will always sway forwards because the belly goes out and now our whole body orients forwards. They breathe out, they come back. So they will constantly have an unstable basis support. Where if they
Mm,
breathe three-dimensionally, which is what great singers and instrument players and marksmen learn to do, they do that three-dimensionally so their body stays stable. That's a real sign of efficient is if you can stand up and do a diaphragmatic breath and you don't waver at all, you know that you have a more efficient diaphragmatic breath.
Interesting. That concept really makes sense, and actually it's helpful because I'm doing it right now, and the vertical makes so much sense to me. That's actually helping. I'm like thinking like breathe down,
Yeah,
and you have to
breathe
kind
down.
of keep that breath.
And even feel in your pelvic floor that the breath reaches down there.
Mhm.
And just
Yeah.
let's just talk that pelvic floor for just a second. I have never had a woman come in with endometriosis or any kind of uterine problem or any kind of well, I've had some with fertility problems that were good diaphragmatic breathers, but most of them aren't. Individuals with bladder problems usually never engage the bladder with their breath. Part of the health of our whole system, of our whole digestive system, is that rhythmical movement of it, just like the oceans against the seashore. That rhythmical movement down of that breath keeps everything healthy down there. Our kidneys,
Mm.
our whole digestive system, our liver, all are healthier when they are repetitively moved through diaphragmatic breathing.
Interesting.
So
So it's
that
not
person who
just
holds their, I'm sorry, that person who wants to have a six pack will immediately stop keeping their system healthy because they stop that rhythmical movement by not being able to breathe diaphragmatically. And so six packs are one of the most dangerous things we've got in our society.
that's interesting. I never knew that. I never thought of that. Wow. And so when
Well,
you're
now just even, and I'm sorry to keep
like
interrupting you,
us.
but I want you right now up a six pack. You're out on the beach right now, and you want everybody to really see that wonderful belly of yours. Can you breathe into your belly?
No. I'm
No.
always trying to hold my stomach in. That's probably my problem, actually. But when you do relax, I mean, does your belly kind of hang forward though in correct breathing?
Well, go look at pictures of hunter gatherers.
Yeah, so that's
Look at
not
Buddha.
good. So how can we do this?
We have to learn to be able to not get overweight, not to get out of shape, to keep
Yeah.
our abdomen strong but not rigid. The
Yeah.
abdomen's meant to be able to contract and relax. When we hold a six pack, it never relaxes.
Yeah. That makes
And yet,
sense. We need that expansion, like what you're saying. And now I'm thinking of it as like how you said it keeps everything healthy, pelvic floor, your organs. And it's not
all of them.
just by increasing oxygen by being a
Yeah.
better breather, but the movement, you're saying that vertical and three-dimensional movement keeps things healthy. It's like right? It's
I would say if
muscular.
I'm a pelvic floor specialist, The most important thing I start with is diaphragmatic breathing.
Mm-hmm. Interesting.
So
Okay.
all of my patients that I work with pelvic floor issues, bladder, digestion, uterine, prostate, I will usually begin with exercises and training in diaphragmatic breathing, vertical
Yeah.
diaphragmatic breathing.
And what I've learned from you also is you can't just cognitively teach these things like put your hands here, belly breathing, but the patient needs functional manual therapy, resistive, like the training you have with resisted breathing and movements to actually exercise the muscles correctly to
Yep,
be able to allow that occur unconsciously or subconsciously.
absolutely.
Hmm. That makes perfect sense. So now this kind of leads my brain to go down this fascia route. So I'm starting to think of fascia. They say the tongue is connected to the toes. And can you talk about fascia, what it is, and this whole body connection of like tongue to toes, if that's something you agree with?
Yeah, and I'm probably going to do another around the way of getting to the answer.
Do it.
So I
I love
apologize
it.
for doing that. For me, when I was at 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑, one of the doctors was a Rolfer. He had been trained by Ida Rolf. And he came in and started presenting to us about fascia. Well, all I knew about fascia was that's what ended up in the bucket at my table of where I was doing our cadaver work, dissection, was that it was the stuff we got out of the way because we thought it was worthless and not important. So we didn't study it, we didn't look at it, we just cut it out and put it in the bucket because it was there with fat and all those other things. So we couldn't see the nerves and the muscles we thought were important. Well, the more I've studied fascia, and that's really when I began, and that was my foundation of developing soft tissue mobilization, is that up till then, the only thing the PT profession did was massage. And so they would treat muscle tone through, never really look at those fascial sheaths. So let's just start basically as to what is fascia. It is a covering. It is a protective covering. It is where we separate everything. In fact, from every individual cell in the body to every organ, muscle, everything else, none of them ever touch each other. They are all separated by loose connective tissue. That is really important for us to know because that loose connective tissue now is the mediator of that relationship and the interface of that relationship throughout the body, cell to cell, muscle to bone, muscle to nerve, nerve to blood vessels, all throughout the viscera, everywhere within the cranium, our whole brain. The loose connective tissue is the foundation. But also recent research shows that in the infant, in the fetus, as it's developing, what is developed first is the scaffolding of fascia. So let's talk about the upper extremity, that as that fetus is starting to develop its upper extremity, the first thing that expands out is the fascia, creating the scaffolding in which the humerus space is already there, and then the body populates that space for the humerus. Every nerve, every blood vessel, every muscle in that extremity is first of all already set for where it's going to position itself by the laying down of fascia. Therefore, it's not wrapping like I always thought it was, like a Christmas package that you threw off the wrapping. It is the structure, it's the framework
Really?
of
I
our
never
whole
knew
body.
that.
Yeah.
Okay. I thought
And
it was kind of like saran wrap type
me
thing.
too.
This is so neat. Okay. Wow. I never knew
So
this.
that's why it's so important. And I didn't mention it in the vagus nerve, but the myelinated fascia, the myelinated nerves of the vagus nerve are the easiest to become inhibited. In the fascia, or in the musculoskeletal system, the fascia is one of the structures that's easiest to become dysfunctional, to
Mm.
lose its pliability and flexibility. Therefore, at all those interfaces, it alters how those structures work with each other.
Wow. And how can fascia lose pliability and flexibility? What would cause that?
Well, probably the most way is trauma that's unresolved. That's on the physical level, that it doesn't truly heal the fascia, or it's on the emotional mental level that we haven't yet let go of that trauma, and it further encases that fascial tissue. And a lot of times as we're treating the fascia, our patients will have memories of that trauma and say, oh, that's when that happened. I remember that now, because they have not resolved that inside themselves. And so fascia becomes dysfunctional through trauma, through overuse, disuse, not staying active. We know that all it takes is someone to be in a cast for a month period of time, and there's a dramatic change in the mobility of their fascia. It is that adaptable that it loses what's called the 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑, or the gags. That is what brings in all the fluids of the ground substance, and therefore the ground substance is less, and the fascia no longer has good lubrication. And so it doesn't slide on itself.
And I assume maybe surgery would be a direct
Surgery is a
problem.
great one. And I would say that any surgery should always be treated after surgery to enhance that fascia's mobility, because it
And
will be lost, to deal with that scar tissue, to help it develop efficiently.
okay, so if one area is the fascia is damaged or lost pliability, flexibility, does that kind of impact all these surrounding areas? And
Completely.
yeah.
I have seen where in the old days when appendix scars were extensive. Now we don't do that because they're doing it laparoscopically. But those appendix scars, scar down affects the cecum below, which is a critical point of the transition from the small to large intestine, and affects the way that right hip functions. And in my early stages of treating scar tissue, it was the one that I saw the most. And I would treat out fascia, and somebody get up and say, wow, my neck's moving a lot better. I can't believe how I can lift up my shoulder. Boy, I feel like my foot's more stable on the ground. You'll see throughout the whole system a change, because that fascia is continuous throughout the system. It's all interconnected. You put a stitch in one place and it alters that whole system.
That's amazing. So now that leads me to thinking about tongue ties and tongue tie release. And a lot of patients might, as a side, impact of getting a tongue tie release, have some of these experiences you're talking about where like they release emotions, they can breathe better, and like, why releasing the tongue? And all of a sudden the shoulders drop and they can diaphragmatically breathe. Do you feel there's validity to that, and why might that be?
You bring up a really good question that I've been studying a lot,
Okay.
but I can't say that I've got fully evolved thoughts on it at this point. But first of all, there's no question that a tongue tie in infancy limits the ability for breastfeeding, latching, and the development of the oral facial muscles, and the ability to be able to expand the face and the hard palate and the nasal cavity. There's no question a tongue tie affects that. I'm full believer in that. I am probably more liberal in this than a lot of individuals who say, well, wait and see and everything. I don't see any reason to maintain the tongue tie. I just have never been proven to me. And the younger you can get rid of it, the less problems. Now, as you get into adults, tongue ties have become a stabilizing force in their system. To better explain that, when we're born, our tongue is our most advanced muscle. We don't develop cephalocaudal like we're taught in school. We develop tongue caudal.
Hmm.
Our tongue is our most advanced organ at birth. And so as that tongue develops, it develops according to its freedom. You put a tongue tie in there, and all of a sudden, it can't do what the genetics of their body is demanding it does to get true control. And so we see that individual who can't truly use that tongue, because of a tongue tie, doesn't develop their throat properly, their voice properly, their pharyngeal muscles. We see effect throughout that system of how that core comes in because of that tongue tie. So for me, it's about the core of the whole system, not just about feeding and breathing, that I would say I would universally have all infants with a tongue tie have a release.
Mhm.
Now let's go back to adults. Those adults, having used that tongue tie to develop their whole motor control system, depend on it. They depend on that tongue tie, and it creates tension within their system, but it also creates their core. So some individuals release, and it's a miracle because it relaxes their whole system. They feel new freedoms. Their posture improves. So many things happen, and it's perfect. But in a certain number of individuals, they so depended on it to facilitate their core, they completely lose core stability. I've had one individual who's a physical therapist. It took her 2 weeks. She had to be off work and everything just to be able to overcome a tongue tie and the impact it had on her motor system. And she had to go through PNF really to get training again of how to get their core. So I think that in individuals with a real severe tongue tie, that you can start proving that that tongue tie is essential for their core contractions. Those who have particularly EDS and other kind of syndromes like that, I would go more along what Sagi's doing with some individuals, is to do 2 to 3 different releases to just find out how they respond. A single release that's only partial to see how they do with that, to really
Mhm.
understand. So that's one of my recommendations.
And then
Uh,
maybe supplement with, like, specialized physical therapy and, of course,
and mild,
myofunctional therapy.
absolutely.
Yeah, that definitely. We always, and all of our release providers require at least a month of myofunctional therapy before a release and then
Yep.
after, because it's the tongue tie release is not a means to an end procedure, but it's just part of our overall goal of establishing correct oral rest posture and good functioning, chewing and swallowing. And you don't just release that and expect things are going to go correctly. The body needs to be trained, the muscles need to be trained.
Yeah, and regretfully up here in Steamboat, we do not have a myofunctional therapist. And therefore, it is so much more difficult in those cases because you are absolutely correct. Every patient that I've ever seen that has undergone myofunctional therapy before and after really responded so well to it. It's the proof's in the pudding. Even though you've got some great research to prove it, it's already makes sense that that's
Right.
what you want to do. And regretfully, the person that I'm describing did not do that. And
Yeah.
regretfully, uh, I think at AAPMD last year, somebody presented that it's only somewhere around 40% of tongue tie patients are getting myofunctional therapy.
Mhm.
You know, and a
Mhm.
lot of individuals who really aren't into myofunctional therapy are learning how to do the laser release because it's a good income without really doing the proper teamwork that's needed. And you and I know that treating these complex patients, there's no individual who's capable of doing it on their own. We need
Right.
a team. We're
Right.
all about having to
That's
have a team around us.
that's the universal message. We all play our individual roles and we come together to help people, but separately, not one of us can help these they're multifaceted problems. So in isolation, we can't fix all these issues. And I'm fortunate where I am that our release providers ensure the patient has myofunctional therapy actively at the
Perfect.
time. Yeah, but it's funny because we do have some parents who might not be honest and tell the release provider that, oh yeah, my child's in myofunctional therapy, but they're not. So there's a system our release provider has with us where then they could go and verify, and we're like, no, we don't know that patient, or we did an evaluation 6 months
I like
ago, but
that.
they're not in therapy. So it's an important step that good providers are aware of.
And I think it's essential for those listening to our podcast right now to really emphasize this importance. Identifying a tongue tie is one thing. Managing that tongue tie really does take a multiplicity of different interventions. Yes, some individuals go in and have their tongue tie released and they do great afterwards and you don't see any negative responses. But I even think in that population, they'd be better off if they still went through the mild functional therapy ahead of time. And for me, I'd want to do my functional manual therapy to the hyoid bone, to all of the muscles around the tongue, to the throat, to the pharynx. Before that tongue's released, I want to prepare it. And I want the hard palate expanded so that tongue now has a better chance of being able to rest on the rugae, which I'm sure will come up in the near future as the importance of our resting position of our tongue.
Yep, the rugae is like the tread on a sneaker for the
Good
tongue,
way of
right?
saying it. Yeah.
Yep, that's how my mentor would describe it. It's like that the tongue should be resting up on the rugae. It's like tread on a shoe. So you say like you treat fascia. So what does that mean, treat fascia? What do you
That's
do?
what we were talking about,
No,
fascia.
we're great. I love this. Like where all these different topics are coming. But what does that
Excuse
mean,
me.
treat fascia? No problem. With
So,
you being
treatment of fascia.
Mhm.
You have to first be able to see and understand and palpate all the interfaces. So, that would be the interfaces between muscles, the interface between the skin and the muscle and the basement membrane in which the fascia all attaches to. It's being able to identify individual nerves, like the vagus nerve is in the carotid sheath with the carotid artery and the jugular vein through the neck. We have to be able to have that palpation to identify what is the mobility of that vagus nerve in relation to those surrounding structures, and being able to selectively identify areas in which it does not have normal mobility, and then applying techniques to enhance its mobility. And that is being able to identify those interfaces where fascia exists and be able to treat them. Also, in my opinion, many trigger points are actually directly related to inefficient loose connective tissue between the individual cells of that muscle. And so we're actually going in and reorganizing through trigger point work and dry needling those individual cells, but more than anything, the fascia around them.
Because those trigger points are causing like referred pain, right? And
Yep.
so perhaps you're saying maybe there's problems with the fascia that are component to that. And when you
Yeah.
release the trigger point, you are helping the fascia and kind of turning off that connection.
You know, when Travell and Simon did their original work on trigger points and really started looking at it, some of their early beliefs was really the fact that why do we have some trigger points that are symptom producing, that get radicular symptoms? Why do we have others that never are affected? And
Mm,
for me, it's when I palpate the ones that are not impacted and do not have symptoms around it, they have mobility around all those tissues and cells in that
mhm.
area.
Hmm.
Those that don't completely lack it, and they become very, very hard, dense structures in there that we need to go in and help free. So I
So
think there is the history.
the trigger point, it's a muscle though, right? When you
Is well, it is in a muscle,
okay.
but in that muscle is fascial tissue
Mm,
that interfaces within it. So we're talking myofascial structures whenever we're looking at it. And some individuals believe that it's the muscle cell that's truly causing the trigger point. My theory is that it's more the fascia that surrounds those cells that becomes the primary dysfunction.
hmm. Interesting. And would you say it's like there's increased muscle tone at a trigger point,
Yep, no
whether
question.
it's from the muscle itself or the dysfunctional fascia
Yep.
surrounding the muscle? Interesting. Okay. So then this leads me to start thinking about muscle tone. So there's like in some online groups, people were commenting back and forth, and there was some confusion. And I thought, let's ask a PT, let's ask Greg Johnson this question about muscle tone versus muscle strength. So some people were saying you cannot change muscle tone, you can only impact strength. And people have said like a myofunctional therapist should not say you're changing muscle tone in the mouth. Um, and maybe not neurologic patients, like maybe a patient with Down syndrome will always have a lower baseline of their tone. but can you change muscle tone? And how can we impact the resting tone of muscles? Are we able to do so?
Wow, that is a really complex question, but it really comes back to poor definitions of those two terms. Tone is used to describe spasticity in a neuro patient. They have increased tone. Tone is also can be described as that somebody, let's say, who always clinches and uses their masseter a lot, and that masseter muscle is working more than it does in other individuals. But it has a habit pattern. When you hold a six-pack and it becomes habitual, there's increased tone in those abdominal muscles. There is tone in them. It's not strength, it's tone. When you have a trigger point, there's increased tone in that trigger point. So, and there is what is described by neurophysiologists, resting tone. So most muscles have a complete relaxed state, but there is still electrical activity who have those muscles capable of contracting. It is called resting tone. And so all of those are different kind of tones, and it depends what you're talking about. If I'm talking about the tone of a trigger point, you guys absolutely help that. We're talking about the tone of a clincher, and you train that masseter to no longer clinch. That is changing tone. If we're talking about resting tone, there's nothing needs to be done with that. Now, the confusion sometimes comes is that individual who is a clincher, you would think would have more strength in those masseters, but it's not always true. The masseters actually become weak because of the overexertion of using phasic muscles to do something like clenching. Same thing with holding your abdomen in. Your abdomen doesn't necessarily prove that it's stronger. In fact, we often in classes have individuals that say, well, I brace myself, I clench up, and I can prove to them that when I push on their shoulders, doing what we call lumbar protective mechanism test, they will not be near as strong when they hold that tone as they are when they relax and let the mechanism of the automatic contraction come in. They'll be much stronger. I've never had, but probably one day will, because you cannot in the human body ever say always.
Or never.
It doesn't exist.
Never say always, and never. I forget what the name is.
Yeah, but whatever it is, you will always be proven that somebody will break your always.
Yeah.
So I'm sure someday I'll find somebody who can brace, who's stronger than they are when they relax completely, and then allow the natural mechanism of the body to respond to an external force. So in that tone, resting tone that is high often decreases the strength of contraction. And it doesn't necessarily mean that they are strengthening themselves to have a better muscle contraction, because strength itself partly depends upon the neuromechanisms that cause that contraction and the ability for those nerves to do it. It's not just about how strong an individual muscle fiber can contract. It takes the nerve to facilitate it. And in a lot of individuals with holding patterns and that clinch or something else like that, they do not increase strength, and they are impacting the neuromechanisms to those muscles because they lose their normal reciprocation that they need.
And maybe a neurological patient, for example, a patient with Down syndrome, they might not have that neurological connection to increase tone. So that's where the breakdown is.
Right.
Okay, but a patient that doesn't have a neurological disorder where you strengthen the muscles of the tongue, and you increase tone, so you get the tongue functioning correctly where it rests instead of like low and forward and relaxed, you increase the strength, the resting tone, so it's resting up on the roof of the mouth, we are impacting, would you say that's impacting the tone of the muscle?
Okay, now it's again definition.
Okay.
Because if we talk about the different gradients of tone, so let's talk about the tongue. If I let my tongue rest in the floor of my mouth and I'm not doing anything active, its resting tone on EMG would be low. There'd be very little activity going on. So I would say that resting position has a resting tone that is low. The minute I push my tongue up against the roof of the mouth, I have an ongoing contraction that is now there constantly. It is one that the muscle is designed to have constant contraction. It is different than the abdominal muscles. And so it is designed to be able to have that tone. Its resting tone, when it's up against the roof of the mouth, is higher. But that resting tone is not pathological.
Okay, yeah, so it's a good thing. So by doing exercises or retraining correct function, we can increase the tone of oral
And
facial
the strength.
and the strength. And,
Yeah.
and
If you use the definition of resting tone,
okay,
it
of
depends what
resting.
they're saying on there is you can't affect tone. Well, if they're talking trigger points
Mhm.
in that as tone, or they're talking about clenching, you can affect that.
And resting tone you can impact.
Absolutely.
Okay, that's what I want to. Okay, and that's interesting. That
I
tone
don't
and
know that
strength.
I've given full illusion to that or illumination to that, but that's at least my opinion.
Yeah, and it makes sense. I think a lot of it's semantics, like what you're saying, like what exactly are we talking about? But it's interesting that you can increase tone and not increase strength. Like they don't always go hand in hand. And
They
that's a
don't.
really interesting thought. So, my mentor, when she was teaching me and training me, we do a we do a lip meter to measure lip strength with the button
Yep.
and the lip meter, the spring tension gauge. And we only do that on patients who have an open mouth resting posture.
Right.
It doesn't matter the strength, and this is what she taught me. The lips don't have to be strong to keep them closed. So you don't need to test that on someone whose lips are closed. If you did that and their score is really low, it wouldn't matter. We just need to restore correct tone of the lips. So if someone is an open mouth breather and they score a really low score on that spring tension gauge, that lip meter, we're going to do strengthening exercises and we're going to retrain neurocognitive awareness for them to notice when their lips are open.
Yep.
And things to increase tone, like press the lips together, hold a toothpick or a tongue depressor between the lips for awareness. But in my office, we stop doing like a button pull exercise for strength when they're at least 80% sitting with the lips closed, because it doesn't matter what their strength is anymore on the lip meter. We stop testing that, because if they're resting with the lips closed most of the time, then we stop worrying about strength. So it just makes me think
Yep.
you can increase tone and strength can be like a moot point. It doesn't necessarily matter. You can
Now,
have weak, your lips don't have to be strong to have them closed. They need to have good neurological tone.
that is it is all awareness of position. And then when you get that lip seal, it changes everything. But I would put a caveat in there.
Mhm.
I do have patients who have a good lip seal that in resting, it appears that for some reason really can't create a lip seal around a straw and they lose sucking ability. They still need to be strengthened because they've got the resting position, but they don't have the strength that puts a seal in there to be able to suck.
Like
Because usually they are ones that
round the
never got
lips. Yeah.
breastfed. They had the bottle stuck in there, and all they did was they never used their lips in bottle sucking, so they never used their lips, but they may have developed a closed mouth resting position.
Yeah, so there's more rounding of the lips and more functional problem than just resting closed, but the suction swallow pattern is a problem.
Is
Okay,
affected.
yeah, that's interesting. So this is also why, like I've been asked sometimes, or maybe been doubted or questioned by maybe some sleep doctors or different people who are like, how does myofunctional therapy work to get the person to breathe better when they're sleeping? How is the tongue going to stay up when they're sleeping? They're asleep. They're not aware. Their muscles are in a low state of tone. And of course, when we enter into REM sleep, our muscles are in their lowest state of tone. So that's when things are going to be the worst. If we need good muscle tone, that's when it's going to drop the most. But it sounds like the correct way to explain this is the exercises and correct functioning can increase the correct resting tone, which those muscles will maintain when sleeping. Because we're not floppy when we sleep, our arms don't fall out of their sockets and things like that. There is still activity in muscles.
You're correct.
Okay.
You're correct. And so there isn't a lot I have to add to this, but I would basically say that what they're discounting by saying, how can it change in sleep, is the recognition that if some individuals can sleep with their tongue on the roof of the mouth and have their mouth closed and not go to mouth breathing, not go to snoring, not end up with sleep apnea, how does that individual get to that state? And our goal is how do we now get somebody to that efficient state? We should be able to do that. If one infant finally develops up to being an adult that keeps their mouth closed and sleeps perfectly without snoring and sleep apnea, and another one doesn't, there should be some mechanism that first one used to get there through the developmental sequence that the other one didn't, and we can take them back through that and redevelop it. All it is the motor patterns exist in the brain for them to sleep without snoring and sleep apnea. It's there already. They just haven't tapped into it. It's our job to help them connect to those motor patterns.
Mm-hmm. Yeah. And a lot of that too is not just doing certain exercises, but changing function, because it's the function, right, that's going to impact that resting tone as well. For
Absolutely.
example, I'm just thinking like you can do 100, like I call them suck it ups, but other people might say tongue clicks or whatever.
Yep.
But if you're chewing with a thrusting pattern and swallowing with a thrusting pattern, you're going to change that muscle tone in its resting state as well, right?
Correct.
I picture like a PT, like if you have a patient that has like an abnormal gait pattern and you just have them like do exercises to like move the ankle or whatever, and then they walk incorrectly, it's never going to carry over.
You're right. All it takes is one component of dysfunction that we miss in our evaluation to perpetuate a problem. It really is the re-education of the whole system to that state that at this state of our knowledge, we determine as an optimal state. And that is what we're trying to help that individual gain. And it has to impact their sleep. And I would say there's just no question to me clinically how many patients come back to me and say the changes there. How many husbands and wives have come back and said, just with the training you've done, the manual therapy that you've done, he's not snoring at night. He's not tossing and turning as much. He's not gurgling, all the things there. And I haven't retrained his sleep. I've retrained his motor patterns so that his sleep now can be in line with those new motor patterns.
Mm-hmm. So in terms of like the muscles of the tongue versus like other muscles in the body, the tongue has type 1 and type 2 muscle fibers. It's different than like other muscles in the body. Could you talk about that as we sort of wrap up? Because I know I'm taking a lot of your time. Maybe we can
I'm
get
actually having so much fun. We
Okay,
can
me
keep
too.
going a little while. The tongue being a muscle that's part of the digestive system has both digestive system components to it and also musculoskeletal components to it. Therefore, it's type 1 fibers, which are used for that resting tone of the tongue up against the roof of the mouth, are automatic in their firing because it is what they're designed to do. They're designed that way. Since the dawn of mankind, mankind has been resting their tongue against the rugae of their mouth. That we wouldn't have those rugae there. They don't just exist out of an accident. They exist because they have purpose, as every structure in the human body does. And so I would say that those type 1 fibers in there are regulated by a nervous system that's partially digestive and partially autonomic nervous system.
Okay. And then how would you describe like type 2 muscle fibers?
Well, type 2 muscle fibers are what we have to use to be able to speak. They're the ones that perform the tongue enunciation ability. So they have that movement skill to them. They're the ones that we use to, if we're playing a trumpet, to be able to do staccato kind of sounds. They're the ones that we use in certain aspects of swallowing and chewing to move food from side to side. They work together with the type 1 fibers, but those are the ones that do the movement of that food so that we can masticate and then eventually get it to a point where we swallow. And the swallow has both musculoskeletal components to it, but a lot of it is autonomic nervous. As you know, you get food certain far back in your mouth and you can't stop the swallow. Swallowing is automatic.
Yes.
It is dictated by different fibers than I use for speaking.
Right. So front of the tongue being more type 2 muscle fibers for fine motor movements, for speech, quick movements, versus back of the tongue more type 1 resting tone, which is what we impact and can help our patients with sleep disorder breathing by changing the muscles at the back of the tongue. That rest. Interesting.
And that's where that posterior tongue tie comes in so importantly, that is now really being discovered. As a frenulum is one thing, but a posterior tongue tie totally limits that posterior aspect of the tongue to do that automatic component of swallowing.
Yeah.
And so that's why I go in and do a lot of aggressive mobilization to that posterior tongue and its muscles to enhance its mobility if I can. And if not, I recommend them for a posterior tongue tie release.
Yeah, getting good mobility of the mid and back portions of the tongue is almost more important than the front of the tongue. A lot of people with those anterior ties, there's also that mid or posterior type of component, but there's different compensatory patterns in those patients, and maybe it has to do with more of those type 1. I don't know, the back of the tongue being more impacted. I don't know. It's just interesting. I know they find sometimes anterior tongue ties patients are having less of a problem than those with just that mid posterior restriction. It's just interesting. Like, I bet there's going to be more information and research on that as time goes on. Like, why are some people doing fine the way they compensate versus others where it doesn't appear as severe or having more of breathing
Exactly. And just to add into that, Nicole, one of the things I can't wait to get to AAPMD each year is to see the new research that they've got on the impact of tongue ties. It's just one of those components that the amount of new knowledge year to year is exciting to me. And I love that component because I think we're going to know so much more 10 years from now and may look back and say, boy, the things we said back then weren't quite accurate.
Yeah. Oh yeah, that's for sure. And it's always just interesting how the field continues to progress. And I heard that there might be a specialty in the American Physical Therapy Association, Airway, like a board certification or a specialty area. I know Brad Gilden is trying to push that, which that's a pretty big deal, right?
It is. And if you haven't had a podcast yet with Brad, I'd give you a 2 thumbs up to do that because the man's brilliant, he's passionate, and he is really making a change in our profession. He single-handedly brought the PT profession into APMD. I just followed him in and do the best I can to help support the drive that he has there. And also, he is now working hard to see if we can become part of the APTA through some mechanism so that we can get airways and the understanding of the importance of airways and feeding and tongues and oral cavity issues and TMJ really into mainline physical therapy and into our education system. I think it's a goal for 20, 30 years down the line that physical therapy leaves school with an understanding of the many things that you and I have been talking about.
Yeah.
We're outliers right now in the PT profession.
Yeah. It's interesting, right? And the PTs that I work with there's some of them that have taken myofunctional therapy courses, and then I've trained them in my specific techniques and approaches, and it's changed their career, the way they treat their patients, the way they view and see their patients. And it's kind of a missing link in many of the fields, is the airway realm, breathing, jaw structure, and how that cranial facial respiratory complex and how that fits into whole body health and everything.
And I would just encourage anybody listening to this podcast, if you find this interesting, if you have patients that you really know have airway problems, which if you don't have any, I want to come and see your patients. I want to know what you're finding. But I'd say don't miss AAPMD. Join that organization. It is an organization with weekly podcasts that are great. And I would just say it is really a resource for those of us recognizing the importance of our airways, our breathing, our sleeping. All of them are intertwined, our digestion, etc.
Yeah, and their conferences every year are called Collaboration Cures because they bring together all of these different disciplines. And I feel like such a dork when I go to those conferences because to me, it's like Disneyland for like an adult. Like I'm like running around going to each thing. It's so fun and engaging and entertaining, and you're surrounded by your airway family. Like we all get it. Like, we're outliers in certain situations, but there we are all united and understand that what so many people don't know, don't realize yet. I add yet because this will be universal knowledge more at some point. So Gregg Johnson, thank you so much for all of this time. You're amazing. It's just so fascinating talking to you. I think physical therapists are some of the smartest people. When I talk to the PTs, I'm like, how do they know? You have to know everything, the whole body. It's crazy. I'm like just this zone. And like, how do you do all that? It's amazing. You guys are the smartest people. Thank you. Thank you so much for all you do. And thank you for being here.
Well, thank you very much for inviting me.
You're welcome. Take care.
Thank you.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.